Our final subject for this issue of ACCEL features the discussion Anthony DeMaria had with Dr. Richard Fogel, CEO of the St. Vincent's Medical Group in Carmel, Indiana, and president of the Heart Rhythm Society. They'd cover the disconnect between the guidelines, the appropriate use criteria, and reimbursement coverage decisions, the ultimate dilemma.
Richard, perhaps you could give us the background of your study. What was the issue that you were studying?
Well, the main problem is that for implantable cardioverted defibrillator implantation, there are the guidelines endorsed by the American College of Cardiology, the American Heart Association, the Heart Rhythm Society. And physicians, electrophysiologists, cardiologists have really been trained to follow the guidelines of your professional organization. And for years we've done that. As it turns out, those guidelines are different in some cases from the payment criteria that CMS has established. So you have a disconnect between the professional society guidelines and the payment criteria under Medicare. On top of that, now you also have the appropriate use criteria established by a panel of cardiologists and electrophysiologists, which expand somewhat upon the guidelines, but are also different from the payment criteria from CMS. And as many of the listeners know, there is a Department of Justice investigation into ICDs that were placed and billed for under CMS, but that did not follow the CMS payment guidelines. And this has created a big problem for the field because certainly as a practicing cardiologist and practicing electrophysiologist, you don't want to be charged for fraud by CMS or by the Department of Justice. But at the same time, you really want to do the right thing for your patients. You really want to follow the guidelines, and you don't want to violate the payment law by taking good care of your patients. So it puts physicians and their patients in this horrible dilemma. And that's what we were really trying to address in our manuscript.
It really is a problem. There's no question about many areas of cardiology, but particularly with regard to ICDs. Now, in terms of the issue of what happens when a physician acts in the treatment of a patient in a way that is different than what the reimbursement guidelines dictate. You know, we have a paper that we've published in JACC a while back that gave the results of an audit that was conducted specifically for ICDs written by Jonathan Steinberg, where the audit turned up a number of cases where ICDs were implanted outside of reimbursement guidelines. They then, by mutual agreement, reviewed each and every chart. And in the vast majority, I recall about 85% or more of cases, the federal government said, well, we see there's a rationale for this, and so we would accept it and accept that that should be reimbursed. Do you think that that's a reasonable strategy?
The first thing I would say is the DOJ, Department of Justice, could have rigorously enforced their national coverage determination criteria. And to their credit, they engaged some prominent cardiologists and stakeholders, and they created what they call their enforcement categories. And it is possible that the Department of Justice chose not to enforce a fraud claim in certain situations. But there are a couple problems with that. One, there are a couple buckets that they call them that I think many cardiologists would still disagree with, because according to the guidelines and according to the appropriate use criteria, we still should put defibrillators into those patients. The other problem is that DOJ, what we call in the paper the DOJ bucket list, only applies retrospectively. In other words, that DOJ settlement resolution model only applies to things that have been done in the past. That doesn't apply to defibrillators that are put in going forward. So it's just basically a legal mechanism to settle these fraud claims against these hundreds and maybe even thousands of hospitals and physicians to make a settlement. But it doesn't really change the guidelines, and it doesn't change the national coverage determination going forward. So just because something fell within one of the DOJ buckets historically doesn't mean that you can do it going forward. And the DOJ resolution model is very explicit about saying that. So I applaud them on one hand for recognizing that there are clinical circumstances that they shouldn't enforce. I personally don't think they went far enough. I think there are some circumstances that they should have chosen not to enforce in addition to what they've already chosen not to enforce. But the trouble is, going forward, it really doesn't help us because we could be back in the same situation in a couple of years because the national coverage determination for ICDs was last updated in 2005, and it really does need an update.
So what is the solution? What would you recommend? And, most of us would sit back and look at this and say, a rational person, if they see that there's a large number of cardiologists who are behaving in a manner that's outside of the reimbursement guidelines, they'd look at this and they'd say, well, maybe we better look at those reimbursement guidelines. Why is it that something isn't changing?
The interests of the American College of Cardiology, of the Heart Society, of the American Heart Association, and the interests of the Center for Medicare and Medicaid Services should be aligned. Our patients are their beneficiaries. I really want to see a very open and transparent dialogue between the professional societies and CMS, because what really needs to happen is the guidelines and the AUC need to be congruent with the payment coverage determinations. And basically, as I said, our patients are their beneficiaries. We all want what's best for our patients. And we've got to break this disconnect. We've got to realign all the interests. So what I'm calling for, and what I think the paper calls for, ultimately is an open, transparent discussion, because that's what being a doctor is all about. And that's where we should go. Now, there are some things you can do in the short term. You can use a wearable vest to get through a waiting period. If you know that you're putting an implantable defibrillator in and it won't be covered, you really shouldn't bill for it. And if you're going to bill for it, you need to have a discussion way up front with the payer saying, here's what I'm doing. I know that it's not consistent with your payment guidelines. I'm letting you know this. In my mind, it's not fraud if I'm trying to do the right thing for the patient. You as a payer can choose not to pay for it. But I'm not trying to be deceptive in any way. All I'm trying to do is do the right thing for my patient. And I think as doctors, that is our primary obligation, to do the right and best thing for our patients. I would really strongly object to anybody who doesn't agree with that.
Your paper raises an important issue, and I really congratulate you for bringing this up, for the committee that put together this proposal. We've got to get an answer. We've got to get some resolution, and hopefully this manuscript will go a long way in producing that resolution. Thanks very much for being with us.
Well, thank you very much for having me.
And that concludes this edition of ACCEL for October 2014. For details about studies discussed on ACCEL, refer to the written summary included as a PDF file on this disc. This issue of ACCEL qualifies for up to 4 Category 1 CME credits. To obtain CME credit, go to www.audiodigest.org/online testing. This is Alfred Beauvais for the American College of Cardiology. Thanks for listening.